So let's talk about some specific criteria, if you can. What are the criteria that you would use as a payer to determine coverage for aflibercept and ranibizumab, those two drugs to start, and whether you're going to cover them at all versus please start with something less expensive?
Yeah, it's basically whatever the label says. We would cover it to the label, and certainly for Medicare, they're covered according to the label.
What about Medicare Part B versus commercial coverage? Is there a difference?
In our plan, essentially the answer is no, that we try to keep them the same.
What about your plan? Is there a difference between commercial and Medicare Part B?
So when you say commercial, unfortunately, that's not just a single policy. So for
you mean there's just not one carrier in the United States?
Nor even within my plan can you say, well, this is a quote-unquote Blue Cross plan, because you will have many variations of what's covered at what rate, and it's a very challenging space.
Healthcare is confusing. Where did I hear that recently? But seriously.
About the label, it's interesting that the label really defines how these plans or these policies are administered. And one of my frustrations as a retina specialist is that the labels are crafted from the phase 3 trials. The phase 3 trials aren't there to determine how we're to use this in our clinics. They're there to get FDA approval. And so as a person who's been involved in designing these trials and executing these trials, we're looking for safety and efficacy approval of the FDA. And we include a very narrow window of patients. They're very on a structured regimen of treatment, but not every patient will fit into that. And that's a challenge. That's a challenge when you have somebody that does not fit the label, which a large majority of the patients in our clinic can fall into that. If you look at the strictest guidelines for it, it's a challenge to then have to deal with a policy that is crafted solely after the label.
Well, and what I should have said is that we start with the label.
Yeah.
We also, if it is something that is, quote, off-label, and payment is requested for that, we do look at the medical compendia. And if there's evidence in the compendia, then we will cover that also. And in fact, for Medicare, we're obligated to cover compendia-listed products.
Right. But again, I guess what you're saying is that a lot of the trials are there to get approval, but they're not necessarily clinical guidelines going forward.
Right. So I'll take a sort of a personal example. I treat a 92-year-old gentleman. He's a war veteran, a physician. He's retired now, and he just happens to have bilateral lesions that require treatment every 3 weeks. If we go out 3 weeks and 3 days, he has loss of vision. We see exudative activity. We have correlation between his anatomy and the vision. And yet I have this payer pushing against me to prevent him from getting the treatment that he needs to continue to see in both eyes.
So are they restricting the number of injections? Is that
correct? And the intervals between the two.
Intervals.
If they say, well, it's 21 days rather than 28 days, this is not a covered service.
Speed dial.
And you mentioned that I've dialed that number a bunch of times, but it's always busy and no one responds to my email.
Try Siri. Maybe it works.
Well, I've tried. And our specialty society is really helping to try and get involved.
Because that's a no-brainer. Of course that person needs it every 3 weeks.
So, and then you mentioned the labels. Well, there's no label for Avastin. So you think, well, maybe I could skip an Avastin treatment in between. Well, there's a policy against that. And that makes no sense if you're saying, well, our policies are label-driven. Well, we have something that has no label for it for our use. Then we should have a lot more freedom to use that, and really that's not the case either.
And the dosing frequencies are much more loosely defined than the indications.
So for this gentleman, who's required, dependent on these medications, our practice has to make a decision. Are we going to let this person fall to his policy, or are we going to step up and bear the burden of the cost of his treatment? And that's a challenge as somebody who's running a medical practice.
So I'm not sure if this is going to help you at all, but other plans will not regulate the dosing schedule to that degree. And I know that doesn't help you in this particular case. Right. But to Gary's earliest point that this is not high on the radar screen, so we are not going to manage the dosing interval to that level of specificity.
I'm glad that you your plans are not, but just, I know that Charlie, as he smiles a little bit over there.
No, certainly.
You know, you've stayed out of the fray a little bit.
Right, no, I was right in the fray for a long time there. So certainly across the country, ASRS is seeing this a lot. There's a lot of plans around the country, fortunately you two are not, that are certainly very tight about the 28 days. If it's less than 28 days, they will not pay it. And yet there's very good literature to show that some patients, a small percentage of patients, actually a tiny percentage of patients, probably less than 5%, do benefit from more aggressive dosing.
So Charlie mentions the label, and I'm sorry to kind of harp on this, but
Go ahead.
the label for ranibizumab says about every 28 days. The clinical trial, actually, there was a window, and it was from 23 to 37 days that you could have gotten that injection.
Absolutely.
So if we're going to mirror the label or the trials at least, let's look into some of those windows when we develop a policy.
And if your patient has Medicare, CMS regulations absolutely require exceptions to any recommended doses that might be in the label.
So my patient is contacting a senator. So, I mean, you know, but it's sad that that's what it's taking now to get some of the patients the care that we need.
I mean, is it foreign to you to hear this more? I mean, if you claim that, gee, if you apply to me, I'm going to approve that, and you only use the drugs that are on label, they're telling you that out in the real world, it's different.
Oh, so to clarify, I'm well aware of these conversations that go on. It just doesn't happen to deal with wet AMD right now. So,
Okay.
So that's, but in other areas and other treatment courses, it does very much go on a daily basis.
Well, it goes on with them for AMD,
Yeah.
right? This is
Yeah,
what you're dealing
regularly.
with.
Yeah.
So, I mean,
So
this is
for
what
me,
doctors are
it's
complaining.
a big deal because I would say about 1/3 of the patients that I see on a daily basis, I'm treating this particular case. I'm treating the wet AMD patient who's having to see me on a regular basis for treatment. And so, you know, if you have a busy practice like mine, you have a few patients that all of a sudden run up against these policies, it can take substantial efforts from the practice to continue to be able to manage them.
Yeah, I mean, I realize that, you know, our practices get enriched for these challenging patients over time because the patients that are doing beautifully and need fewer treatments, well, you're seeing them less frequently. And it's the ones that need intensive dosing that seem to accumulate. So we do see these patients regularly. They come up all the time. I mean, the other example that's thrown around a lot is every other month dosing versus every month dosing. So initially, the aflibercept trial showed that monthly dosing and every other month dosing were, from a visual perspective, non-inferior to each other, identical.
For the patients in the trial.
For the patients in the trial. But even anatomically for the patients in the
Yeah.
trial, there was a benefit to using monthly dosing on a population. But if you drill down into the data, and this didn't come out till 3 years after the original trial was published, but if you look at it, 20% of patients actually do better if you continue monthly dosing versus every other month dosing. So you need to individualize therapy. It's hard to be cookie cutter about a disease that's so variable across patients.